One of the issues that we get called at the office about regularly are sleep issues with Parkinson's, and we have the great honor to have Dr. Anupama Kale here today to talk a bit about those sleep issues. She was educated at the American University of the Caribbean School of Medicine. She served fellowships at the Medical University of South Carolina, just the connection with Dr. Hinson, as well as the University of Missouri, Columbia, certified in neurology and sleep medicine. And we're very pleased that last year she joined the Dent Neurologic Institute, come to our community, and help serve our people. So I'd like to welcome Dr. Kale.
So like I try to tell all my patients, I tend to have a soft voice. So if at any point you cannot hear me, please let me know. Because as I continue to speak, my voice sometimes goes down. So I have the pleasure of speaking to you about sleep at a time you're probably feeling very sleepy. So I will not take any offense to any naps that I see. So as Chris was mentioning to all of you, I've done training in both movement disorders and sleep medicine. And so talking about sleep issues and Parkinson's is of great interest to me. And so hopefully today we'll be able to cover some issues. It's a very complex issue. And so I'm always free for questions afterwards, but we'll try to cover some of the bigger bases. While I learn how to use this. Okay. So just a brief overview of what kind of topics we'll try to discuss today. So when we talk about sleep issues in Parkinson's disease, we want to talk about what sleep disorders are actually associated with the disease itself. And then we want to look further into what actually causes these sleep disorders. Is it the disease itself, like I mentioned before? Is it symptoms of the disease process? Or is it medication side effects? We also want to touch base on what kind of treatments are available for sleep disorders, and then overall, what kind of information and clues do sleep disorders actually tell us? And so before I even talk about sleep in Parkinson's, I do want to touch base on what is sleep itself. So all of us spend about a third of our lives sleeping. And so it's a very natural thing. We really don't think about it. The more we learn about sleep, we realize how intricately tied it is to our energy levels, our mood, different physiologic processes. So as a very basic definition, as far as behavioral terms are concerned, sleep is a normal, recurring behavioral state, which is reversible. It includes a loss of awareness, and it also includes the inability to perceive and to respond to the external environment. And the reason I'm mentioning this is because we'll talk about how some of the sleep disorders affect sleep in this sense. When we look at normal human sleep, there are two primary parts to it. We have non-rapid eye movement sleep, and that comprises of 3 stages of sleep that we go through. And then we have REM stage sleep. So when we go to sleep at night, there's this very specific order to the stages of sleep that we go through. And normal sleep architecture for a normal, healthy adult usually includes cycling through these different stages. And so we cycle through non-REM sleep first. We've got stage 1, stage 2, which are the lighter stages of sleep. We go into slow wave sleep, which is stage 3, and then we eventually get into REM sleep, which is the deepest stage of sleep. One thing to remember about REM sleep is it's our dream state sleep. What happens during REM physiologically is that we actually lose tone in all of our body. That means that we're essentially paralyzed, with the exception of our eye muscles and our diaphragm to, of course, help us breathe. We go through these stages one by one throughout the night. Each cycle lasts about 90 to 120 minutes. And as you can see, as you go through the night, the REM stage sleep gets longer and longer. And so this also becomes important when we look at parasomnias that affect our REM sleep, like REM sleep, our REM behavior disorder, which I'll talk about in a moment. So one thing I wanted to mention is that this is actually the 200th anniversary of James Parkinson's A Shaking Palsy, which is very important. Can you imagine? This has been described for over 200 years. And actually, in his first description of patients with Parkinson's, he actually touches upon the sleep issues that affect patients with Parkinson's. And he mentions that in this stage, the sleep becomes much disturbed. The tremulous motion of the limbs occur during sleep and augment until they awaken the patient. and frequently with much agitation and alarm. So like Dr. Hinson spent a lot of time this morning talking about, the more and more we learn about Parkinson's disease, the more and more we learn that it is not just a movement disorder. There are several non-motor symptoms that are a part of this. And so non-motor symptoms are now recognized to be integral to the whole treatment of Parkinson's disease. Not only do they occur at the onset of Parkinson's disease, in fact, they can occur much earlier, sometimes decades earlier. And so a lot of times, and hopefully, as we start to do more and more research, we'll be able to identify these non-motor symptoms so that there's a window of time that when that neuroprotective therapy comes out, we can actually treat people before their motor symptoms develop. Dr. Hinson went through all of these. Of course, I'll be focusing on the sleep disorders. So of course, we learned earlier today also that non-motor symptoms are often the most predominant source of disability in patients with Parkinson's disease. They not only negatively impact life, they can cause impairment in the quality of life of patients. And this was shown in many studies, especially when you're studying patients 33 to 90. Upwards of a good 40% of patients will experience some sort of sleep disturbance during their disease process. So there's an estimated prevalence of about 90% of sleep disorders in patients. It actually increases with the advancement of disease. It can be positively related to, or you can consider these risk factors, older age, male gender, those patients who are on higher levels of dopamine, and also those patients who, as part of their disease, exhibit more cognitive impairment or psychiatric issues like hallucinations. The problem is that we're learning more and more that this is inadequately addressed. And this is because of two things. One is that it's often underreported by patients. Like I said, we all go to sleep, we all have an issue here and there, and we don't think to mention it to our doctor, especially not our Parkinson's doctor, because they're treating our movement disorder. And the other part of the puzzle is that it's often under-recognized by health professionals. And so there are a couple thought processes as why sleep is actually affected in Parkinson's disease. One is that dopamine, the main chemical that we think about when we think about Parkinson's disease, of course there are many more, that's thought to be involved in promoting wakefulness and arousal. There has been research that suggests that an altered sleep pattern in Parkinson's disease is actually due to primary degeneration or slowly dying off of those cells that are actually involved in the control of the sleep-wake cycle. There's also a significant percentage of sleep complaints in Parkinson's disease patients that are thought to actually be due to our circadian rhythm. And so we don't have time today to talk about circadian rhythm as such, but there are two types of body mechanisms that help us go to sleep. One is an alerting mechanism, and one is one that makes us sleepy as the day goes on. So sleep disorders in Parkinson's is going to be multifactorial. You can have a pure sleep disorder, you can have sleepiness or sleep-related issues due to medication, and then of course you can have nighttime symptoms that are actually related to your Parkinson's disease. So a few of the main sleep disorders that we talk about when we think about Parkinson's disease include REM sleep behavior disorder. To put it simply, that's when someone acts out their dreams, and we're going to talk about it a little more. Insomnia, which is just basically a difficulty falling asleep or actually maintaining your sleep. There's restless leg syndrome, which is actually also a clinical diagnosis like Parkinson's disease, where people either have difficulty falling asleep or staying asleep because they have a creepy crawly sensation or leg discomfort, which is associated with an urge to move. People have sleep apnea, and there's two types of sleep apnea that we'll talk about. And then people also experience sleepiness during the day, something we call hypersomnia. And so REM sleep behavior disorder, for me as a movement disorder specialist and a sleep specialist, is particularly interesting. As I talked about before, when we go into our dream state sleep, all our muscles are essentially paralyzed with the exception of our eye muscles and our breathing muscles, mainly the diaphragm. All the accessory muscles are paralyzed. What happens in patients who have REM sleep behavior disorder is somehow this mechanism is lost, and so they are then able to act out their dreams. And so, for example, patients may be chasing an assailant, they may be fighting with their friend, and so they'll actually physically act out these dreams because now they're enabled to. What's interesting is that patients who experience REM sleep behavior disorder often have very violent dreams. And we still don't know why, because they've actually done studies to look at daytime, rates of aggression in these people, and the people tend to be very calm. So it's not like these are angry people who are then having angry dreams at night. The typical behaviors that we see, and there's a whole myriad of them, but especially hitting, punching, I'm highlighting these because kicking can sometimes represent a different sleep disorder. Sometimes people laugh. It can range from people mumbling in their sleep or actually having snippets of conversation. People who have REM sleep behavior disorder, however, generally do not walk, okay? They're not interacting with their environment. So whereas they may fling their arm out and hit an object, they're not grabbing their object and interacting. They're also not talking back to a bed partner. And the reason I mention that is that if you exhibit some of these behaviors, you might mistakenly think you have REM sleep behavior disorder, when in fact you might have another kind of sleep disorder. And a lot of the sleep disorders actually overlap. So when we look at what are the different disease processes that could be happening, we want to make sure that we're ruling out a parasomnia or abnormal behavior that actually happens in non-REM sleep. We want to make sure we're ruling out sleep apnea, and I'll talk about why. And then, of course, like I said, kicking can represent different things. Yes, you may be kicking and acting out a dream, but you might also be having periodic limb movements of sleep. So, as I mentioned before, this is a very interesting area of research for people because it gives us a lot of clues about Parkinson's disease. What's interesting is that spouses of patients who have movements, they note that actually patients are rather strong and they move quite fluidly as far as their movements during sleep are concerned, almost as if their Parkinson's was cured. So as we know, we all have, with Parkinson's, have small movements, but sometimes when people are acting out their dreams, they have very smooth, large movements. They've also found that there are similar findings reported in patients that have the atypical Parkinson's syndromes, like multiple system atrophy and progressive supranuclear palsy. So once we start to study this more and more, this could potentially lead to development of treatments, and then it can also overall shed light on how we control movement. The other clue that it gives us, and this was touched upon earlier, is that a very large percentage of patients who develop dream enactment behavior or acting out their dreams, when they actually followed these patients over time, the ones that had presented to sleep centers with this problem, they noticed that in about a decade, maybe 10 to 15 years, a majority of these people actually developed a synucleinopathy like Parkinson's disease. So why is this important? When they did those studies where they followed the different patients, they were actually able to see that these symptoms preceded the onset of motor symptoms like the tremor or the slowness by an average of 13 years. So again, when that time comes, and it will, where research is able to give us an agent that actually protects us from the disease, this is going to be the window of time that we want to look at. Other things that we know about REM sleep behavior disorder as far as acting out their dreams are concerned is sometimes it can be associated with different subtypes of Parkinson's. So as many of you know, some people have tremor predominant disease and some people are more slow and stiff. And for whatever reason, we're learning that people who act out their dreams tend to be the slow and stiff type, but that's not an absolute. So when we look at how we treat REM sleep behavior disorder, the number one thing we want to make sure of is bedroom safety. And so this is a very old picture of a patient. So unfortunately, several years ago, there weren't too many things on the market to help treat this. And so this is actually a picture of a gentleman that had to restrain himself to the bed because he was afraid of hurting his wife. And so when you look at your bedroom safety, first of all, if you have a tendency to fall out of your bed, you want to make sure that either you have a bed rail, that your bed is low to the ground, or that you even have some sort of soft support on the bed, on the floor beside your bed, so that if you were to fall out, you don't have any major injuries. You also want to make sure, as I mentioned, you're not going to be grabbing any objects, but all of us have bedside tables next to our bed, and they all have edges to them. cover those edges, somehow put a cushioning on it so you don't break a wrist. So as part of my sleep training, I've seen a lot of patients, not necessarily those patients with Parkinson's, but people can have severe injuries. You know, you fling your arm back into the headboard, you can break a wrist. You can punch your wife. There have been some rare reports of people strangling other people, but that's very less common, so don't worry, spouses of Parkinson's patients. There have actually been some criminal reports of that. So as far as pharmacological treatment is concerned, clonazepam, Klonopin, is actually the most effective treatment. It's effective in upwards of 90% of patients. The problem that we face in our Parkinson's disease population is that clonazepam unfortunately has a myriad of side effects that are particularly important. So for example, it's a very long-acting medication, and so it can often cause grogginess in the morning. And it can cause balance issues. And so as we know, we're getting up to urinate in the middle of the night, we don't want it to be tripping. And so for that purpose, melatonin is actually the better alternative, especially for patients with Parkinson's. And that's because melatonin is a naturally occurring hormone. Its main side effect is sleepiness, and that's why we take it towards bedtime. And that can be anywhere from 3 to 15 milligrams at bedtime. So moving on in sleep disorders, insomnia is something that affects patients to a great deal. And again, when we talk about insomnia, that's just a nice way of saying a difficulty falling asleep or staying asleep. And in patients with Parkinson's disease, they often complain of maintenance of sleep, meaning fragmented sleep. And sometimes people also have premature awakening in the morning. Now, when I say premature awakening in the morning and say you wake up at 3 to 4 a.m., that doesn't mean you're going to bed at 7 a.m., okay? So that means you're going to bed at a regular time and then prematurely awakening. And so fragmented sleep is actually listed as amongst the top 5 most troublesome symptoms in Parkinson's. So when we look at why people are having trouble falling asleep or staying asleep, we have to take a very careful sleep history because this can be very tricky or it can be due to multiple factors. So, of course, as we all know, the symptoms that we treat during the day, the tremor, the rigidity and stiffness, can sometimes reappear at night. And so that might necessitate the use of a long-acting medication like controlled release cinnamon. Sometimes people can have the non-motor cramps that we talked about, the pain, the cramps, and then especially nocturia, or getting up frequently during the night to urinate. So, as we know, a lot of patients have comorbid depression and anxiety. A lot of times I tell my patients that there's a reason that expression, "I got up on the wrong side of the bed," was created. So patients have a poor night of sleep, they have mood problems, or there's a chicken and an egg with that. And so sometimes people it can go the other way around. People can sometimes have nighttime hallucinations, upwards of 20%. And then, of course, it can sometimes be related to the drugs we use when we treat Parkinson's. So one thing, when we look at how we want to treat it, of course, we want to identify the main reason that we're having trouble sleeping. And as I mentioned, if we have nocturnal motor symptoms, we want to maybe try a slow-release cinnamon, or we might want to try a medication that works on more of a 24-hour basis, so the Nucropratch, for example. We also want to make sure we avoid taking those medications that actually have alerting side effects. The main one, and it's one medication that we don't tend to use as much in the movement disorder community anymore, but that's selegiline, and that's because it actually breaks down to an amphetamine. Amantadine, too, is something that we want to take earlier in the day. We want to make sure we reduce our fluid intake before bedtime. Don't drink 3 glasses of water before you go to bed. This might not be able to be avoided in some people, but you also want to try to avoid diuretics. You want to make sure you address mood disturbances. You might want to consider evening melatonin. So even though melatonin treats REM sleep behavior disorder, as I mentioned, it's a naturally occurring hormone that actually helps us go to sleep at night. And our melatonin levels actually decrease as we age. So whereas it might not be as helpful in, say, a 20-year-old, it will be more helpful in a 70-year-old. And then the other thing that we sometimes forget about is impulse control disorder. And this is a side effect of some of the dopamine agonists that we use. And the reason I bring this example is when you actually take a close sleep history as to why someone may be going to bed later and later and later. I actually had a patient who was compulsively checking her Facebook. So that was a compulsion that was actually a side effect of her medication. I want to mention cognitive behavioral therapy here. It's not only good for anxiety, but in sleeps or in studies that have shown how cognitive behavioral therapy affects those people with insomnia, they've actually shown that cognitive behavioral therapy is just as effective, if not more effective, than sleeping medications. And so we want to just make sure that we address, maybe wrong beliefs that we have about sleep, such as, I must get 8 hours of sleep, and then you get 7 hours of sleep and you get upset. And then it also includes a lot of techniques that we can learn, such as breathing techniques, relaxation techniques, biofeedback. So restless leg syndrome is often also seen in patients with Parkinson's. And the main reason we're realizing that is that the condition itself, even though the pathophysiology or the cause of the disease is very poorly understood, we're learning more and more that it actually involves a disruption of the dopamine transportation. Again, dopamine is the main chemical implicated in Parkinson's disease. And so whereas the general population may experience restless legs upwards of 10%, you see that there's a much higher percentage of patients with Parkinson's that experience restless legs. And then this can also coexist with periodic leg movements of sleep. So restless legs is this discomfort, this uncomfortable, indescribable feeling that people feel usually in both their legs, very poorly described, that makes them want to move their leg, and that movement actually makes them feel better. This occurs during the day or when people are awake. If they're kicking at nighttime, that's a different mechanism. As I mentioned, the periodic limb movements of sleep. However, periodic limb movements of sleep, PLMS, has a high association with restless legs. So upwards of 80% of people that kick at night actually do end up having restless legs during the daytime. So when we look at how to treat restless legs, we want to make sure that we treat it if we need to treat it. There are a lot of, sometimes people don't necessarily have symptoms that often. If it comes, here and there, we deal with it. We want to make sure we look at our medication list. Notorious SSRIs or SNRIs or TCAs are notorious for exacerbating restless legs. So our antihistamines or medications like Benadryl that sometimes people take because they think, oh, this is going to help me fall asleep better. We also want to avoid substances like nicotine, caffeine, alcohol, because they can also make it worse. Other non-pharmacological therapies include sensory modalities. So Relaxis is a device that was FDA approved. It's a non-pharmacological device. Basically, all it is it's providing sensory input. And so it's actually quite expensive, so I often tell patients to just go to their local Walmart. You can get like a shiatsu massager, something just massages the legs. They've shown that dopamine and iron are implicated in the disease process, and so you want to make sure you get your iron levels checked and treated if that's the case. And of course, there are multiple medications on the market that we use. Previously, it was thought that the dopamine agonists, the one that we use for Parkinson's disease, were the first-line therapies, but now we're learning more and more that when we start patients on these medications, their restless legs actually get worse within a year or two. Interesting phenomenon called augmentation, and so we're trying to lean away from those medications, though these might be good choices in Parkinson's patients because, of course, they're going to help the Parkinson's disease. And then I want to spend a little more time on sleep apnea. The reason being is that this is a very common illness, and I like to say it's similar to high blood pressure in that it's a silent killer. So when we stop breathing at night, there's a number of physiological things that happen, include a shooting up of our blood pressure and our heart rate that can over time increase our risk for bad things like stroke and heart disease. And so when we look at sleep apnea, there's actually two different mechanisms that occur. One is that there's actually a reduced signal for us to breathe. That's much less common. It's something called central sleep apnea. However, the most common cause is obstructive sleep apnea, and that's usually when there's some sort of obstruction in the airway. That can either be an anatomical abnormality, like a small chin, or sometimes people have excess tissue around their neck. And so, of course, when they're lying back on their back, gravity is working against them and unfortunately compressing their airway. So as far as the prevalence with respect to the general population is concerned, it varies. However, if you're male, if you're older, and of course if you have a little more body weight, you're at risk for this disease. The one thing, though, this is one thing that's often propagated, which is true. Yes, if you're bigger or have a bigger body habitus, you can have a higher risk for obstructive sleep apnea. But when they've actually studied patients who have Parkinson's and sleep apnea, they actually have noticed that they have a different body habitus. So you could be a thin person with Parkinson's disease, and you could still be at risk for obstructive sleep apnea. And then the dopamine agonists that we use for Parkinson's, unfortunately, can sometimes increase our risk for the central sleep type. Now, when we talked about REM sleep behavior disorder earlier, we talked about how people are often acting out their dreams. Well, there is a phenomenon called pseudo-RBD, so basically something that looks like REM sleep behavior disorder, which has been described in patients who actually have obstructive sleep apnea. So it's important to make sure you tell your doctor about acting out your dreams, and then it's also important to see whether you have loud snoring or gasping of air, because you could actually have obstructive sleep apnea and just be acting out your dreams. And so the gold standard for the treatment of sleep apnea is still something called CPAP. CPAP, all it stands for is a continuous positive airway pressure. It's actually a fairly relatively safe treatment because it's not a medicine. All it is a pressurized stream of air that's shunting your airway open. And then, of course, there's a concern of excessive daytime sleepiness. This is sometimes the trickiest thing to discuss with patients because there's so many reasons someone can be sleepy. This is very common in patients with Parkinson's, and it can affect upwards of 75% of patients. And unfortunately, people feel more sleepy usually as the disease progresses. It tends to be associated with more advanced stages of Parkinson's, more advanced stages of disability, and of course cognitive decline. And then there's also a growing risk of sleep attacks, and that's something that's usually associated with your medication. So for example, the medications that have the highest risk are usually dopamine agonists like your Nupro or your Mirapex or your Ropinirole. One thing that's interesting, though, is that they've done studies that have actually shown that there's a loss of the wake-promoting substance called hypocretin. And so we're starting to learn more and more that patients who have Parkinson's or are sleepy, it's part of their disease process. So when you treat excessive daytime sleepiness, of course, because it's multifactorial, it's going to involve several different treatment strategies. The one thing I want you to remember is that usually the most common cause for why you're sleepy during the day is you didn't get enough sleep at night, okay? That is a number one cause of sleepiness during the day. But then you want to make sure you rule out any kind of underlying sleep disorder, mainly obstructive sleep apnea. However, if people are having those periodic limb movements of sleep, that could actually be waking them up and disrupting the architecture of their sleep as well. You want to make sure that you decrease sleep-promoting medications, so again, the Requips and the Mirapexes. And then in some cases, usually more rarely, because we usually, tease out all these different things. Caffeine I'm not so keen on, but there are some wake-promoting agents called modafinil that sometimes may be of assistance. And then, of course, all of our Parkinson's disease medications, unfortunately, Parkinson's is not a one-size-fits-all disease, and so there are different side effects associated with different medications that actually affect our sleep in different ways. Levodopa, we've seen actually increases the time it takes to go to REM, and it actually reduces our overall REM sleep during the night. We're still learning more and more as to what the importance of REM sleep is. Sometimes people can even have a withdrawal phenomenon where they go into a lot of REM sleep. As I mentioned, the dopamine agonists can cause daytime sleepiness or sudden sleep attacks where patients get very sleepy, and there can have variable nocturnal effects. Selegiline, which is a sister medication of a lot of the medication that many of you are probably on, Rasagiline or Azilect, as I mentioned before, can break down into amphetamines and cause wakefulness. Azilect actually in some studies have been shown to increase or improve sleep quality. Anticholinergics like Artane or Amantadine can cause daytime sedation, and then Amantadine in particular can sometimes be associated with nightmares. So hopefully, you've got a sense that unfortunately the management of sleep disorders can sometimes be challenging. It's something that you have to work with your physician and give them a good sleep history. It's multifactorial, it's complex, it's not a one-size-fits-all. And so in cases like this, treatment has to be individualized. So we're going to end with just some few tips for better sleep. This is not just for Parkinson's patients, but for patients overall. And sometimes they're very intuitive, but we don't do them for whatever reason. So I often tell my patients that our brain likes regularity. It's a habitual organ, okay? So you need to make sure you go to sleep at the same time. You need to make sure you wake up at the same time. And of course, there are going to be days that maybe you're out with friends or watching a movie where something gets a little later. But as far as possible, you want to keep a regular sleep schedule. You want to make sure that you sleep only as much as you need to feel refreshed the next day. Again, a lot of people get, pulled into this, I must have 8 hours of sleep to be healthy. That's not necessarily so. For most, healthy adults, 7 to 8 hours is necessary, but there are some short sleepers where 4 to 5 hours actually makes them feel refreshed. You want to make sure you avoid daytime napping. We didn't talk much about it, but our circadian clock is based on 2 drives, one that makes us more sleepy and one that alerts us. And when we sleep during the day, we're essentially giving our body and our brain the wrong signal that we don't necessarily need to sleep at night. And so it disrupts our sleep architecture at night. You want to make sure you get bright light in the morning. This is also going to help. You want to make sure you get a steady amount of exercise. As we know, that's going to be good for a whole host of things. And then, of course, you want to keep temperatures moderate in the room. Actually, as we sleep and as the hours go by, our body temperature dips, and it actually likes cold temperatures. You want to make sure you insulate the bedroom against sounds that might disturb you. A lot of times patients will say, "Oh, I'm waking up," but then when you actually talk to them, their dog is beside them and moving around and rustling or barking. Sometimes a light snack before you go to sleep might help because you don't want to wake up during the night and get hungry. Again, you want to avoid excessive fluids at bedtime. You certainly want to avoid alcohol because alcohol can actually disrupt our sleep architecture and the quality of our sleep. So whereas one glass of wine might make you sleepy, it has the potential to actually disturb your sleep later on in the night. You want to make sure you use the bedroom. It's actually for the 3 S's. It's going to be sleep, sexual activity, and sickness. Try not to use your bedroom as a hangout place. Go out into your living room and do something else. Don't take your problems to bed. And of course, don't stay in bed if you actually can't sleep. So for example, if you're waking up in the middle of the night, you're just lying there awake, you want to make sure you take yourself to an adjacent room that's dimly lit, do something very boring until you get drowsy, and then return back to your bed. Because if you stay in bed, you're going to develop these negative psychological associations. So take-home points for today. We now know that sleep disturbance is very common in patients with Parkinson's. It's very important to screen and report your issues to your doctor. Good sleep hygiene is important. It's going to include any kind of behavioral modifications as well as medication management. You want to make sure you evaluate and treat for any kind of comorbid conditions. Safety first, especially when you're thinking about REM sleep behavior disorder and keeping your bedroom environment safe. And then, of course, if you're feeling sleepy during the day, I want you to avoid drowsy driving. Don't get behind the wheel. But hopefully, if you get improved sleep, this will lead to an overall improvement in your mood, your cognition, and your motor function. Oh, I went backwards. Give me one moment. And that's it.